Okay, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you've read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content which is provided as is and without warranty. For all athletic trainers who are intending to get live CEUs from the VOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customer care at gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review tomorrow. We are super excited about our speaker tonight because we have received so many requests from our athletic training attendees regarding this topic. So Bryan Caplan received his Doctorate of Physical Therapy from the University of St. Augustine. He previously served as the Staff Physical Therapy Director, Regional Director, and has been the current Assistant Vice President of Medstar Health Physical Therapy for the last decade. Bryan is a concussion, throwing, and manual therapy specialist. He is speaking today on the sources of TMJ dysfunction in athletes.
Thank you.
Yes, I am going to click this over. You should get a little button pop up to allow you to share your screen. Perfect. Fantastic. Okay, you are in presenting mode and we can hear you.
Awesome. Thank you so much for having me. I appreciate your patience as well, as I know that I had to reschedule a couple of times. I would like to correct you. I think my curriculum vitae may have been wrong. I have been the assistant vice president for the last year. It has not been 10 years, although it feels like it. Just a little bit about myself. As she mentioned, I went to University of St. Augustine for physical therapy school. University of St. Augustine, for those of you who are familiar with it, are a very manual-based, spine-based school. We focus a lot of attention on cervical spine, thoracic spine, lumbar spine, and the jaw as well. So as I came out as a new grad and patients were being referred for temporomandibular disorders, I was pretty quick to say, absolutely, I'll treat it. And what I found is finding a therapist that wants to treat that dysfunction is pretty hard to come by. And so I've gotten lots of referrals over the years. Unfortunately, within the last year with my role change, I'm doing less patient care, but I do see TMD patients and concussion patients sporadically, which has been helpful. And I absolutely love teaching and educating. I miss desperately being a clinical instructor. So I appreciate this opportunity. Just to get started, I have no conflicts of interest to report for this presentation. I have no relevant financial disclosures as well, and I will not discuss any products at all in this conversation. So here's our objectives and what we're kind of seeking out today. I'm going to go over some anatomy and biomechanics briefly, discuss some of the symptoms and outline what we do from a physical therapy exam, and then review treatments as well. And if you want, I'm not sure how you guys do this, but if there's questions, you need to go in the chat. I'm happy to get to those as we move through this. So we'll get started talking about the TMJ anatomy. So the TMJ, as commonly it's known as, is temporomandibular joint. So as you can see from the diagram down below, you have your mandible, which is your jawbone, then you have your temporal bone, and where they intersect is your TMJ. So I don't know if you can see my cursor, but it's the TMJ right there. There is an articulation within that. As you can see, there's a disc that's in between the condyle there. And that typically is what we're dealing with when we're hearing, feeling, cracking, popping, crepitus, all the above. And you get a little bit of a view of the pterygoid muscles that are in here as well. The TMJ's primary responsibility is to move your jaw. And believe it or not, it's the most commonly used joint in your entire body. TMJ gets all it needs from you just by eating, talking, smiling, laughing, and living your life. So as we get through this, we'll talk more about it, but I'm a huge proponent of using that joint as much as you humanly possibly can, even when you're feeling pain. We'll talk a little bit more about that disc. So the articular disc, very similar to what you'll see in the lumbar spine, cervical spine, thoracic spine. It sits right in that joint where the mandibular condyle is and the temporal fossa is. The disc has very, very interesting anatomy to it in the sense that it's aneural and it's avascular. No nerve supply, no blood supply. Therefore, when you're feeling it, you shouldn't be. And if you are feeling it, that likely means that there's something going on there. Either there's some degeneration in the bone and the cartilage, or that disc is displaced and you're getting some pinching of some of the tissue in there, which is known as retrodiscal tissue, which we'll show you in the next slide as well. But that retrodiscal tissue, which falls right posterior to the disc here, it's a little white area. I'm not sure if you guys can see my cursor, but the little white area that's behind the blue disc there is your retrodiscal tissue. So as you can see, as the disc moves anteriorly, if that retrodiscal gets pulled up into the disc and gets pinched and a little bit of impingement there, it's going to cause a little bit of that pain. And you get another good shot of the lateral pterygoid muscle. That pterygoid muscle attaches directly to the joint. So in a lot of our cases, when that pterygoid muscle is obscenely tight, it's going to pull on the disc, pull the disc out of position. That retrodiscal tissue now falls into the joint and they're going to get a lot of pain. So the key muscles that are going to be involved in this joint, primarily you're going to see temporalis and masseter. That is the most common dysfunction that I find in people is people that have atrophy or disuse or overactivity of those muscles. So if you want to feel those muscles, very simplistically, I'm going to have you guys do this. Go ahead and put your fingers right on the side of your jaw, kind of right on that mandible, and bite down. When you bite down, you should feel your masseter muscles push right into those fingers. If you did not feel it, try to feel it in a different place, bite down. You should feel those muscles push out. It should be a nice, strong contraction. We'll talk about it in the exam phase later, but if you're noticing a small contraction or maybe a really strong contraction or one side contracts before the other, that's what we're going to look at when we look at TMD dysfunctions. The other thing that you can palpate pretty easily is the temporalis. So if you throw your fingers right on the side of your temple there and bite down again, you'll feel those muscles flex into your fingers. So because you're eating, chewing, talking, smiling, laughing, living, you should have pretty active temporalis and masseter muscles. And if you don't, you've probably got TMD. Other muscles that are involved are going to be the medial and lateral pterygoid. As I mentioned earlier, that lateral pterygoid muscle does have a common attachment to the disc. You can see it here in this image above, labeled number 2, your top right there. And then underneath of your chin, several key muscles as well, the digastrix, and genio and mylohyoid. So all very small but very integral muscles, and those are muscles that we will evaluate through palpation, we'll evaluate through treatment as we move forward when we evaluate the TMJ joint. So other things to think about with that joint, just like anything we look at in the body, there are nerves and there are ligaments, and there's vascular supply. So as we evaluate that patient, we're going to look at everything objectively, from the bone to the muscle to the tendon to the ligament to the nerves to the arteries, right? Trigeminal nerve is something that we see very consistently in patients with temporomandibular disorders. Trigeminal nerve dysfunctions can be extremely painful, and a lot of times we are finding that we're evaluating that as we're looking at TMD. Please keep in mind that it's not as scary as it may seem. In most cases, we just need to figure out what's the underlying source. Where is that nerve being entrapped? Why is it being entrapped? And how can we help that? And that's going to alleviate a lot of symptoms. But trigeminal neuralgia is a very, very painful thing. And when those patients are coming to see us with that, we want to make sure we address that as quickly as possible. That's a little bit of the anatomy. So hopefully that was a review for many of you, or maybe new for some of you, but maybe gives you a better snapshot of what that TMJ really does and how it's effective. So let's talk about biomechanics. So as we know, those muscles are going to help move the joints. And what does that exactly look like? So as we go to open our mouth, right, and you can feel on yourself, that mandible is really the only thing that's moving, right? The temporal condyle, or the temporal fossa, so to speak, it's not moving. That temporal bone is not a movable bone, but the mandible is moving. So as you're opening your mouth, that mandible is going to open. It's going to open and start to rotate within the condyle, and then it's going to start to slide down the articular eminence. So what should happen in an ideal world is those muscles and if that disc and that condyle are going hand in hand and moving together, because there's no nerve supply, because there's no blood supply, you're not going to feel it. It's going to be nice and normal. You're going to have good range of motion. You're going to be able to bite, chew, tear, do all the things that you want to do while you're eating, okay? So being mindful of that. The movement is known as translation. So just if you wanted to label it and you're documenting, as that jaw starts to rotate and open and then move eminence and disc together, that's called translation. Anterior translation and then posterior translation, or retraction is what we call it. And when you are biting and when you are chewing, you want those molars to meet, because when the molars meet, the masseter and the temporalis will fire, as we talked about in the previous slides. What I tend to find is that people that have these jaw pain issues tend to want to avoid eating on one side versus another side. And that can kind of lead to a downward spiral of the fact that you're neglecting a muscle, and that muscle is then not being used, okay? I believe I say this in a future slide, but I will say this again. I am not a dentist. I am not an orthodontist, nor do I ever claim to be. But when a patient comes to see me and they are not eating or chewing, I'm generally going to educate if it's safe for them to start doing that, because we want to use those muscles. No different than that patient that comes to see you with an ankle injury. They've rested, it's been about 48 to 72 hours, now we're going to start weight bearing again. But as you know, the longer you go without weight bearing and the more those muscles start to atrophy, the harder the recovery is, the more challenged the biomechanics become. So I'm not going to read this slide. It's a wonderful slide. I put it together. But this talks about biomechanically, what are each of those muscles doing and what does that look like? With that initial rotation and 20 millimeters of motion of the jaw, your temporalis is involved, your masseter is involved, the medial pterygoid is involved as well. As it starts to translate, right? You see that term translation in there. Temporalis again is involved slightly with that, as well as masseter. And then as we start to close the jaw, the digastric, the genio-myohyaloids are involved, and they're also involved with that lateral deviation. So one of the things that we're going to evaluate, which we'll talk about shortly, is how is that jaw opening? How is that jaw closing? How is that jaw protruding? How is that jaw retracting? And then how is that jaw laterally deviating side to side? You need to have all of those motions to be an effective eater, talker, laugher, all the above. So great slide. Snapshot here if you wanted to. This is one of my go-tos, right? When I was in graduate school, their number one thing, if you can understand anatomy and biomechanics, you can treat anything. And I wholeheartedly believe that. So what are we looking at? We're looking at range of motion. This little guy here is awesome. I would highly recommend this if you are going to want to measure jaw. I have these, they come in like packs of 100. You can get them on Amazon. They're not overly expensive. And the way it works is at the very bottom left, you'll see there's a little cutout here. That cutout is going to go right in between the bottom teeth in the middle, and then you're going to have them open. And as they open, you're going to slowly move the top of it up to the top, middle incisors and see what that range of motion looks like. So if you can kind of get a vision of that, the bottom hook is going to go on the bottom teeth. As they open their jaw, you're going to slowly move the numbers towards the top teeth. Normal opening could be 40 to 60 millimeters, okay? We're looking at retraction and protrusion as well as 3 to 9. And with the excursion, what we do is generally what I'll do is I'll turn it 90 degrees where that arrow is, where it says lateral scale. That arrow is going to get pointed straight at the bottom incisors, and I'm going to have them laterally deviate their jaw to the right, laterally deviate their jaw to the left, and that stays in the middle. And I'm going to see how far out their jaw is coming on that scale on the bottom, upwards of 8 to 12 millimeters. The biggest thing that we want to look for there are deviations, right? And they're very noticeable. If somebody has difficulty opening, you're going to notice. If somebody has difficulty laterally moving their jaw, you're going to notice as well. But from a documentation objective measure standpoint, this is what we're using. These are our norms for those measurements. So some biomechanics to think about as well. The jaw is one part of all of this. The vast majority of these cases, and we'll talk more about this as we go, are posture related. It's one thing if there's trauma that occurs in any injury that we see, right? We see someone get hit in the face, take a ball to the face, take a foot to the face, land on their face, trauma. Okay, I'm all about that. Same thing with an ACL injury or a rotator cuff injury. If there was trauma, we can easily manage that. If there was no trauma and the patient comes in and they say, you know, this has been going on for years now, nothing really brought it on, it just started, I usually generalize those into posture-related syndromes. And here's something really important to think about. Posture precedes everything. My favorite statement is posture, position, performance. If your posture is good, your position is good. And that position includes bones, muscles, tendons, ligaments, nerves, arteries, all things we talked about in the anatomy section. If your posture is good, your performance is good, right? So if posture is good, the positions, everything's good, your performance is going to be good. So with the jaw, you're going to be chewing, biting, eating, yawning, talking, laughing, smiling, no problems whatsoever. But as your posture changes and position of these muscles change, position of these joints change, that's where the problem ensues, right? So from a forward head, rounded shoulder standpoint, which is the vast majority of people, my education to patients is always everything we're doing all day is in front of us, right? So you're sitting all day. What are you doing? Are you on a computer? Are you on your phone? You're driving your car, you're eating your food, you're brushing your teeth. Everything that we're doing is anterior. And what tends to happen is those anterior muscles get shorter and tighter. And so if anybody ever did any research or talked about Vladimir Janda talks a lot about that and posture and positioning, right? A short and a tight muscle is a weak muscle. A long and a lengthened muscle is a weak muscle. So if you think about it in that sense, that patient that comes to see you, let's talk about the teenage kid, the teenage athlete that comes to see you, and they're sitting in your office, and your first observation is just, how are they sitting there? They're slumped over, they're forward. What you already know is that you have anterior shoulder posture, which means your anterior chest wall is tight, usually pec major, pec minor, maybe the lats are tight, the biceps are tight, posterior chain is going to be weak. And then that goes into the neck as well. With that forward head, you're going to have super short and tight anterior neck muscles. like longus capitis and longus coli. On the back side, you're going to have shortened, weakened muscles like rectus capitis posterior major, rectus capitis posterior minor, all that suboccipital triangle that we learned about. What's really interesting is that when you have forward head posture, your tendency is going to have a subcranial backward bend, because if we don't have that and you have a forward head posture, you're always going to be looking down, and your body's goal is to always right itself and find the horizon. So if you're kind of sitting there and you're thinking about it, okay, if you're slumped forward and your head's forward, you can't live that way. So you're going to get a subcranial backward bend, which means your OA, your occipital atlas joint, and your atlas axial joint are going to be now in a shortened and hypomobile position. Most of these patients that we're seeing, if we do mobility testing on their OA and AA joints, they are significantly limited, and by just loosening them up can help translate all the way down through the jaw. So again, those weak anterior neck muscles, you're going to have weak posterior subcranial muscles and weak posterior chain scapular muscles. Those rhomboids, those posterior rotator cuff muscles, generally going to be weak, as well as those muscles of mastication. We're going to find that temporalis isn't doing its job, masseter's not doing its job, digastric, the hyoids, all of those muscles, because they're out of position, can't do their job. If you don't get anything else out of this lecture and you're really just stumped on what do I do for this athlete or this patient that I'm seeing that's having jaw issues, just start with posture. Just start there. It will make a world of difference. So diagnoses. So we talked about our anatomy, we talked about our biomechanics. Let's talk about diagnoses. TMD is the diagnosis, not TMJ. That's kind of a pet peeve of mine, is everyone always says, oh, I have TMJ. Yeah, everybody has TMJ. That's the joint. But the true diagnosis should be TMD. So make sure we're labeling that correctly. We're documenting that correctly. Temporomandibular disorder, not temporomandibular joint. Everyone has a joint. So TMD dysfunction or disorder. What are some causes? So I mentioned earlier trauma. Of course, trauma is probably the number one thing. I think most of us on this call out here are athletic trainers, if I'm not mistaken. But you're probably going to see more trauma on the field of that jaw joint and what that looks like. Remember, if the joint is coming out of position, that's going to affect the disc, that's going to affect the condyle, that's going to affect opening, that's going to affect closing. We're going to talk about that shortly. Dental dysfunctions, again, I am not a dentist, nor do I ever claim to be a dentist, but I do see a ton of patients, and when we take our history, most of these patients have had dental issues. They've had braces or a mouth guard or crowns or some dental work done at some point. They have various bites. Again, not my specialty. I know enough to be dangerous, but I'm never ever diagnosing anybody with, oh, you have an occlusive joint or you have an overbite. None of those things. Arthritis is a disease as well that you're seeing a lot in people, and those joints can start to degrade. The cartilage on the fossa, the cartilage on the mandibular condyle, that's going to cause some grating and popping. Posture, as I mentioned. Extreme muscle dysfunction, again, if things are out of position, they're not going to perform. And then lastly, and again, something that I think is really tied into this for the vast majority of our patients is stress and anxiety. And so recognizing that our patients that have high stress and high anxiety are usually living in a sympathetic nervous system. Their body is just overrun by that sympathetic nervous system. And most of those patients are going to report clenching, grinding, or bruxism at night. As you know, at night or at any time that you're resting, that parasympathetic system should kick in. So if you're sleeping and you're laying in bed and your jaw is moving, your parasympathetic system is not all there for you. And in all likelihood, you're in sympathetic overload. So I find that I spend a lot of my time talking about stress management, mindfulness, all the above with our patients, because again, the patient is a whole individual. It's not just that jaw that we're talking about. And I always want to seek out what's that underlying source and what can I do to help them long term. again, without being too challenged, focusing on posture, focusing on breathing techniques and stress management techniques can go a long way for these TMD patients. So what are some signs and symptoms that our patients are going to present with? Tenderness over that joint, of course, pain, grating, popping, teeth grinding, headaches. Most of these patients are coming to us with headaches, and a lot of the stuff that we're going to do is going to domino effect and get rid of their headaches, get rid of their ear pain, their tinnitus, their ear fullness. Sometimes patients are having eye issues as well. You know, just another thing, I don't have a slide in here about this, but just recognizing compensation and what that looks like, right? I really like the analogy of a GPS system. Your body has specific firing patterns, right? When you go to bite down on that piece of chicken, your body has a firing pattern and it's going to go bang, bang, bang. If it's out of position, it can't do its job, the body's going to immediately compensate. It's going to route that GPS somewhere else and start selecting different muscles. One of the biggest things that we see is with those forward head, rounded shoulder postures, those smaller proprioceptive muscles in the head and neck that I was talking about earlier, rectus capitis, posterior major, minor, inferior oblique, superior oblique, those muscles can't do their job to hold your head up as well. And so larger sympathetic chain muscles take over. And the primary one that we see in most cases for most patients is upper trap. Upper trap feels super tight on all these people because it's doing too much work. And upper trap is going to basically strangulate occipital nerve on the back of the head. And so kind of tying into concussion, because we see a lot of TMD and concussion going together, the stress, the anxiety, the head trauma, the whiplash, they all go together, right? Like a hamburger and french fries, you're going to see a TMD disorder with most concussions. So just be mindful of, you know, if someone's having ear issues, eye issues, like what exactly is that underlying source? Is it coming from their upper trap? Is it coming from their occipital nerve? Is it coming from the temporal area? But we can very easily treat all the above with a really good treatment session. Let's talk about some of these common diagnoses that we are seeing in our setting as a physical therapist. The most common one is going to be TMJ disc displacement with reduction. So as we talked about earlier in the anatomy and biomechanics section, what we're going to find is that anterior disc translation. So your disc is going to get pulled forward and out of position, and now it's living anteriorly. Again, that retrodisco tissue, which has the nerve and the arteries and the blood supply there, is going to get pinched. That can cause pain. It may not cause pain. Sorry, I spelled joint wrong. So there's the word join. But it can be painful. But most of these patients are getting clicking or popping, and it does not have to be painful. If it's not painful, it usually means that retrodiscal tissue hasn't been affected yet. But here's what you want to think about, right? So as I mentioned earlier in biomechanics, when we're opening our jaw, we have that translation in which the condyle and the disc are moving congruently. But now what's happened is the disc is anterior. And so as you open that jaw, the condyle has to find the disc. And as it finds the disc, it's going to jump onto it and it's going to pop, or it's going to click. And then it's going to move the rest of the way down the eminence, and then it feels good. So as we're palpating on our patient and you have them open and you feel a click or a pop, that guides you to know, okay, this disc is probably forward. Why is the disc forward? Excuse me. Usually in most cases it's because pterygoid is pulling on it, and pterygoid is short and pterygoid is tight. And if we can try to treat that and relax that, and we get the disc back in position, that's going to go away. So with opening and closing, that condyle is going to move over the disc, and then when it comes back, it's going to hop off the disc back into the fossa, and you're going to get that pop again. So you might get a pop on the opening end, you might get a pop on the back end, or you might get one or the other. So that's going to be displacement with reduction, so it's reducing back where it needs to go. Displacement without reduction is going to mean that condyle is not able to get back on the disc. If someone has limited opening, so you go to measure and it's less than that 40 to 60 range, or the patient says, you know, I just can't get my mouth around that big hamburger or that big steak sandwich, generally what's happening is that as they go to open that jaw, the condyle is not able to hop on the disc, and it just can't get there. So they feel like they cannot open. The converse is going to be they are able to get on the disc, they move down the eminence, and as they try to come back off the disc, they cannot get back over the disc, and that jaw will stay locked in an open position. So that patient will usually come in and they'll tell you, hey, I feel like I get my jaw open and then I just can't close it. And usually they'll kind of mess around with it a little bit and eventually it'll pop and we go back in and they can get it closed. I've seen a couple patients that I've treated that it is actively open. Most of those cases, they're going to go see their dentist and they'll get it taken care of, and the dentist will refer to us in physical therapy for evaluation. And a thing that's really important to keep in mind when you look at the anatomy of the disc, which is really, really interesting, if the disc remains anterior for an extended period of time and the condyle keeps rubbing and rubbing and rubbing on the fossa, the body's natural inclination is to scar down, and it will recreate a disc, and it is called a pseudodisc. So a lot of times patients will have these TMD symptoms of clicking, popping, difficulty opening, difficulty closing, and they just resolve on their own because the body's natural adaptation to just fix itself. And if they're not able to get there, that's when they come and see a professional like myself as a physical therapist, and we can try to facilitate that along. I always feel like no matter what, our job is to just coax the body along and help it fix itself. So it doesn't have to be that challenging. I think for most people, treating the temporomandibular joint seems a little daunting. It's really not. I mean, it's very simplistic, and it's no different than understanding the knee joint or the shoulder joint or the spine. I kind of already talked about this, about being locked in an open position. Most of the time, just like heating it, massaging it, mobilizing it, it'll go back into position pretty easily. This is something that you might see in a trauma scenario that you can pretty easily reduce. And I'm assuming as athletic trainers on the field, this is something that you might be seeing. Hopefully everybody's sticking with me so far. We're going to get through examination, and then we'll talk about some treatments, and that's pretty much it. So for me as a physical therapist, my examination consists of, just like everybody else, we're looking at it. So we're looking at subjectives, objectives, and then what's my assessment and what's my plan. The biggest thing is just taking a great history. History a lot of times is going to tell you what's going on there. Make sure as you're taking the history, we're making sure to get a dental history as well. I'm going to say this for the third or fourth time in this meeting. I'm not a dentist by any means. I know enough, but I'm never recommending anything from a dental history standpoint. But understanding dental history can really understand what's going on. Let's say that patient, for some reason, is lacking molars. I've had patients with that before, and that they don't have the ability for their molars to touch when they're biting, when they're chewing, or they have teeth that are missing or teeth that are broken or cavities and they avoid and they're chewing in certain ways and they're compensating. That can play a huge role in this. I had a patient recently that I was treating that had to get implants put in, but they recommended physical therapy beforehand because she couldn't open her jaw fully. And they were concerned that she wouldn't be able to hold her jaw open for the procedure. So she came to see me for that, and it was challenging for me because, again, it's a cycle. She wasn't able to bite down, therefore she wasn't able to get her masseters and her temporalis muscles to fire appropriately, or digastric to do what it needed to do. So when I was palpating on her masseter, she just couldn't get any firing out of it. So we did some things to try to get it going. I saw her for several weeks, and she was able to successfully get the surgery. Once she got the surgery and had new crowns put in, and she started eating and chewing normally, it was night and day for her, and she was a happy camper. Posture, we talked a ton about already. Looking at facial asymmetries is a huge thing. You can pick up on different things of muscle imbalances by looking at, is one eyebrow higher than the other? Is their nose shifted a certain way? But just similarly to how you would look at a knee, right? If one quad is atrophied versus the other quad, if one is appropriate. So just being aware of what facial asymmetries are, and looking at their bite. Oh, look, here's where I said I'm not a dentist, like halfway through. One thing I do with bite is I will, with the evaluation, I will throw on a pair of gloves. I'll put my fingers in their mouth. I'll put my hands on the bottom, and I'm going to ask them not to bite me very hard, but just bite down gently. And what I want to Can somebody confirm that they can hear me? Okay. I don't see that any longer. I think my audio connection was lost. Okay. So going back to the bite, making sure that we're feeling that they're biting equally right to left, that'll tell us a lot about what's going on from an asymmetry standpoint. Tongue scalloping, which is basically looking at their tongue and kind of looking around the edges of their tongue to see if there's any little tears or bumps in there. That'll usually tell you how their tongue is moving in their mouth, or if it's rubbing against the teeth. The tongue is really important, and a lot of exercises we do involve the tongue. Are their scapula protracted? What's their cervical range of motion? What's our strength? What's our neuro screen? All things we kind of talked about. So what does our treatment approach look like? Every approach from a physical therapy standpoint should include three things: manual therapy, education, and exercise. For me, education is huge because most of what our patients are doing are outside of our therapy walls. So I want that patient to be able to understand what to do, how to do it. They're seeing me once or twice a week. That's not enough to get better. I'm going to help you get yourself better. But from a manual therapy standpoint, soft tissue massage, myofascial release, cervical spine, suboccipitals. The auricular is something important too. I'll like grab their ear, move their ear around to make sure the tissue and cartilage behind the ear is moving appropriately. Myofascial release to the TMJ muscles, both internal and external. So I will throw on a glove and do mobilizations internally as well as soft tissue and try to actually get onto the pterygoid muscle, which you can do. And you can also teach the patient to do self-massage of the pterygoid. Remember, releasing that lateral pterygoid can release the disc, which can then improve the biomechanics. Suboccipital distraction is something really important that we do that helps with headaches. Looking at mobilizing their OA and AA joints to get more subcranial range of motion out of it, which will then help the cervical spine, which will then help the jaw. Everything goes together, right? The body is a chain. And then we'll do different mobilizations for the actual TMJ, distraction both internally and externally. I'll do lateral excursion mobs. Again, you can mobilize the zygomatic arch. You can mobilize the temporal bone a little bit at the joint superiorly while inferiorly gliding the mandible, trying to mobilize the maxilla. Any joint mobility in and around that joint will be greatly helpful to improve the biomechanics. And another huge tool that we do is dry needling. With most of my TMD patients, I'm doing some form of dry needling. Upper cervical spine, upper traps, sternocleidomastoid is a huge contributor. We will needle the masseter, we will needle the pterygoid, we will needle the temporalis. So doing dry needling to release those muscles is huge. Then it's going to be the education of how do we keep it that way and the corrective exercise. From an education standpoint, one thing that I'm always going to educate my patients on is their resting tongue position. So in a resting position, your tongue should be at the roof of your mouth. Your lips should be closed. So observationally, patients that are mouth breathers, upper chest breathers that are not belly breathers, that tend to rest with their lips and jaw open, those can be problems. And so quickly educating on, okay, say the word 9. When you say the word 9, what you should find is that your tongue is going to end up on the roof of your mouth, and that's where the resting position of your tongue should be. So I would challenge you for the rest of this lecture to try to focus on where is my tongue at its resting position. Roof of your mouth, lips closed very slightly, breathing in and out through your nose. Mouth appliances. Again, not a dentist, but the vast majority of our patients that have TMD symptoms are going to go have a custom appliance made or an over-the-counter appliance made. From my observation, most of those appliances are made to keep the enamel of your teeth from degrading when you're grinding at night. They're not always overly successful in treating TMD because I feel like that's not the underlying source. For me, it's no different than that patient that has a rotator cuff issue. I don't want them in a sling for extended periods. For that patient that has an ankle sprain, I don't want them on crutches or in a boot for an extended period. The longer that you're using an appliance or something of that nature, it's going to adversely affect the muscles. Also, with the appliance, you're not getting the ability of those masseter muscles to contract. Sometimes that will cause muscle issues, but I will have patients all the time that are biting through their appliances, cracking their appliances. My goal is to say, if it helps you, awesome, but let's do what we can to treat you and then get you back to the dentist to see if we can get you away from it. Teaching the patient self-massage. We mentioned earlier about stress management techniques and getting them away from the sympathetic chain. And talking about chewing. That chewing is good. It's not bad. We want to get them used to chewing on the side that they're avoiding so they can use those muscles appropriately when appropriate. Exercises. I'm a huge proponent of deep cervical exercises. We do a lot with lasers, where we will put a laser on somebody's head and have them track on a target. That's very research-based out of Australia for cervical proprioception and cervical tracking. If you're not familiar with that, I'm happy to share more information about that. I love posterior chain strength, our prone, eyes, Ys, and Ts, anterior chest wall. I do a lot of stuff on foam rolls, have the patient laying lengthwise on a foam roll to open up their chest wall, and while they're on there, maybe doing a pull apart or a band, no money, to help strengthen posterior chain, upper trap stretching, levator stretching, sternocleidomastoid stretching, and then a lot of exercises we'll do for the tongue as well, having them move their tongue in and out of their mouth. I'll have them do things like take a lollipop and put the lollipop in their mouth and use their tongue to move it from side to side, move it up and down, try to get those digastric muscles and the hyoid muscles active. And lastly, most of my patients are getting what are called Rockabato 6x6s. Very research-based. Dr. Rockabato came up with these exercises, which are 6 times a day for 6 reps for 6 different exercises. That's on the next slide that we'll review. Here's some pictures from my St. Augustine guide with how to mobilize and do TMJ distraction in various positions. And here are those Rockabato 6x6s. So it's going to start with tongue in resting position, which is going to be top of the mouth, and then just breathing. Big breaths, focusing on belly breathing, making sure our chest is not rising. As we breathe in, the stomach should push out. As we exhale, it should relax and recoil. Teaching people belly breathing is really huge for TMD because what we'll find is most of those people are upper chest breathers, which uses accessory muscles to pull those rib cage off of the lung field, and they're going to get a lot of tightness in their neck, scalenes, sternocleidomastoid. So first things first, teaching them how to breathe appropriately with their tongue and mouth in resting position. The other thing we're going to have them do is tongue clucking, which is literally making this sort of sound. They're going to do that 6 times. Controlled opening is going to be tongue on the roof of your mouth and opening and closing your jaw. This really helps to improve the alignment and the mechanics of opening the jaw. You'll find that patients that struggle with opening their jaw appropriately, if they keep their tongue on the roof of their mouth and focus on slowly controlling that opening, it will allow for more normalized mechanics. Jaw stabilization is simply isometrics. So as we're having them do that controlled opening, I'm going to have them take their thumbs, put it underneath of their chin, and resist that opening. Count to 5 seconds and relax. We're also going to have them resist lateral excursion, right and left, by taking their thumb, putting it on the side of their jaw, and resisting that lateral excursion. And then laying in a supine position, we're going to have them do nods. A nod is where they're slowly lifting their head off of the table or off of the pillow, which is different than a chin tuck, which is bringing your chin down towards your chest till it feels a little bit pinchy and uncomfortable, and then slowly backing off of that. And then scapular retractions, pinching those shoulder blades together. So there is a link on here that you can click, what'll have a PDF version of what those look like. Most of my patients are getting Rockabato 6x6s. It's something I've done for more than a decade, and it's still successful. So that is it. These are some of my references that I pulled some of this information from, and that is all I have for you guys. So we got some time left over. I'm more than happy to answer any questions.
Yes, we do. We have several questions here. The
Hopefully you guys
first one.
heard all that.
Oh, yes, yes, and we
Yeah, there
could
was a
hear all
certain
that.
point where it said I wasn't connected, so I wasn't sure.
Okay, well, fortunately, we could hear you.
All good.
The first question comes from Ken, and he asks, could you speak to the role of laxity of the capsular ligament, collateral ligament, and retrodiscal ligament? If lax, could this be a reason for anterior disc displacement? Without
Sure.
a tight joint, could the strong superior pterygoid muscle pull the disc forward without the tight joint capsule to stabilize?
The answer is absolutely, and that is a phenomenal question. With joint laxity, if that's coming from some sort of trauma or possibly some sort of genetic disorder like an Ehlers-Danlos or some other connective tissue disorder, absolutely that can affect it. I think that's obviously something way beyond my pay grade in terms of diagnosing. Most of those cases, a dentist or a specialist is going to diagnose those kind of things. But just like with any laxity of any joint, then in that role, it's going to be stability, right? So if something is hypomobile, we're going to mobilize it. If it's hypermobile, we're going to try to stabilize it as much as we can. The Rockabato 6x6s are great for stability, especially that stabilization exercise with the isometrics.
All right, so the next question here is, how common is bilateral TMD? If not bilateral, does this lead to lateral deviation of the mandible, particularly with a lax joint?
Yeah, absolutely. That's a great question, and that's something that I didn't address with all of this. I mean, there was just so much good stuff to talk about, but when you're looking at observation in that history section and you're having them open their jaw, you do want to observe, is it laterally deviating, or or is it opening exactly straight? But yeah, absolutely, we can get bilateral TMD symptoms in a lot of these cases. It does tend to be more dominant on one side versus the other, and usually it has to do with those muscle imbalances. It's usually ipsilateral. If you have like an atrophy of masseter on the left side, as an example, you'll find that the temporalis on the right side equally is atrophied, and that can cause a deviation. Obviously, joint laxity can cause a deviation. But yeah, these are phenomenal questions, and you guys are thinking exactly the right way.
I'm just waiting to see if there's any more questions here from the audience. We had about 80 attendees, just as an FYI.
Well, hopefully this was useful information and you got something out of it. Like I said, you know, in most cases, people seem to be intimidated by treating the jaw, but I think if you look at it as a whole, right, you're looking at the head, the neck, the shoulder, all the above, and biomechanically, it all goes together, right? And so if you just focus on a couple simple basic things of let's look at posture, let's look at cervical stuff, let's talk about breathing, let's talk about stress management. In most of those cases, I mean, obviously we get some complex cases, but in most cases that we're seeing in an outpatient setting, just the simple basics are going to get these patients better. Stick with what you know and don't overthink it.
Wonderful. Well, we'll leave it at that and not take any more time from your evening. Thank you so much, Dr. Bryan Caplan, there for giving us a fantastic discussion on TMD. To be corrected, thank you very much. And thank you to all of our attendees. So this, you know, again, was an idea born of our attendees and met with many of their requests for this topic. So I really appreciate having such an expert come in and talk about it. And that means to you as attendees, if you have any other less common topics that you would like for us to find speakers for, let us know and we will do our best to find someone. So thank you to everyone for attending.
Thank you so much. I appreciate you guys having me.
All right, have a good night, everybody.